So while Barb Given is going to get some water and is going to come back and join us, so one thing I'm struck by, and I'm going to go back to where I started when we put this panel together, and that is we know it's important to screen for distress. So we've got distress screening in there. I'm not going to go further than that. But what I have not seen are those algorithms. We know that cancer care for the whole patient, another IOM report that clearly said we're not meeting the psychosocial health needs of our cancer survivor population. But and Paul Jacobson actually very nicely showed that algorithm. There are 4 parts. You have to screen and assess. You have to have a conversation about what needs to be done. You need to make a recommendation, and then you have to follow back. What I've seen is criteria for the screening and nothing else. So no standard about what's the outcome of that, and do we follow back and see that, I screened, I made a recommendation, and my job is done. But we don't have an algorithm for saying, well, did we address the problem? So I'm struggling, and maybe opening up that for conversation is, how do we do this systematically? What's it going to take? I mean, what do we need? Policies in place? Do we need people in place? How are we actually going to make this a standard part of care?
Can I ask a clarifying question? When you say to put this in place, you mean that we're going to study it in the way you say, or we're actually going to implement it?
We could study it. I mean, perhaps that's a 2-part. Good point. I mean, if we had data except that I feel we have the data that shows if we address psychosocial emotional problems, we don't need that data. We know that if we can improve that, I think there's a sufficient information there to say that if we can improve psychosocial outcomes, we will improve health outcomes. But we're not doing it. And we know, obviously not everybody, that subset of people who are unnecessarily suffering. And how do we get to that and have that be part of routine care?
Well, like I said, I think we built it. It's just that people haven't come, perhaps because there's not enough professionals. The professionals aren't integrated sufficiently with the medical care team. It hasn't actually been all that long that we have been talking about screening and triage care. That isn't something we were really talking about 30 years ago when some of these studies started. And then kind of on our piece, there hasn't been adequate dissemination of the interventions we have in terms of training providers and empirically supported treatment. So I think it's kind of like a problem that has, an octopus of legs. There's so many pieces. I don't think we can point to one, but that doesn't mean we can't begin to make inroads. In terms of the providers I've taught, some of them are just kind of overwhelmed with their workload in terms of the many referrals they get. Others of them, and some of them can control their schedule a bit because they're billing. Those individuals that are in settings that aren't billed have workloads up to their eyebrows. And I think just the provision of psychosocial services is, I was going to say a disaster, but really something that needs to be improved, and not the least of which is integrating it better. But a huge issue is billing.
Yeah, I just want to say I would like to get to the question, so to try to engage in some dialogue, I just want to briefly say that sort of to highlight something I had mentioned earlier in my talk is that I think we've got a lot of data, and yes, I do want to see more research to validate that, but I think that our training programs, starting at medical school level, at nursing school level, can make this standard of care. That this assessment of psychosocial needs for patients and caregivers has to be part of the work. And this is team-based care. I actually wrote a letter to the editor in JAMA that was published that I think we shouldn't be using the word provider. I think we should be using the word practitioner, because we can't provide everything. And we do have tired practitioners, but if we work in a team-based approach with interprofessional care, we can meet these assessment needs. We can meet these psychosocial needs. And I think we can share that quote-unquote burden in that way.
I was just going to say, I think there was a comment earlier today on this side of the room that we are talking about cancer survivorship care in a healthcare environment. And the reality is that mental health care in this country is in a very difficult place. Most people who have a psychiatric disorder never receive any care at all. So if that's the larger context, yes, we could be doing better, but that has a real impact on what we can do, how many providers we have, what we can bill for, how we can integrate. Doesn't mean we can't do better, but I think we are in a context that is very challenging.
Good afternoon. I'm Ron Klein. I'm from CMS, but mostly I've been a pediatric hematologist oncologist for 26 years of my life. So this is a question for Dr. Raklaitis. A little bit in the weeds, and I apologize for that, but you talked about the behavioral problems and learning disabilities and marriage rates and employment rates for childhood survivors of cancer. Can you break that down into those who've received radiation in their head and those who haven't? Because I think most people in this room perhaps don't know this, but brain tumor is the most common solid tumor in children. So a lot of kids with radiation, even up until the early 1990s, kids with leukemia were getting radiation in their head. So I'm wondering if that's important. And the second question, sort of along the same line, just in terms of breaking apart some of those statistics that you lump together, and I appreciate that you're lumping together statistics, is I wonder if age of diagnosis affects things. And the reason I ask that question is I have a colleague who's a pediatric oncologist who had, ALL and had a bone marrow transplant. He relapsed at the age of 4, and I asked him how that affected him. He says, I don't remember any of it.
Thank you. I'll try to respond as best I can to some of the weeds. I think I'll take the last part first in terms of age of diagnosis. I'm sort of chuckling because I took that off my slide last night. Age of diagnosis is complicated because it actually relates to your other question in terms of exposure. So what exposures you have at what age, and radiation is a very toxic exposure to the brain in particular, and even more so when it happens at an early age. So there are those interactions. In general, if you look at the CCSS and you take all comers across diagnoses, age at diagnosis is not a strong predictor. And I think that's because you have different diseases with different exposures at different ages. So going back to the other point, as I tried to make very briefly, that yes, CNS-directed therapy, which happens, for some of our survivors with solid tumors, more commonly ALL patients, and then of course brain tumor patients, is associated with more problematic psychosocial outcomes across the board. But the statistics I was sort of which I was citing, aren't limited to that. So the things I was talking about are worse more prevalent and more severe in the brain tumor survivors, but they're not limited to them, except I think things like major mental illness. Some of the big Scandinavian studies of being psychiatrically hospitalized have found it is more prevalent in brain tumor survivors, but not in other survivors. So there's a lot more. I think if we had the data tables in front of us, we could break it down. But in general, the picture isn't all that different, but I think it's more prevalent and more severe in the brain tumor survivors. And then, of course, things like learning and education are more severe. And maybe those things are kind of more distinct in the brain tumor population and the CNS treated group.
That was a great question. So complicating it, as a developmental psychologist, I'm always fascinated by age time of treatment. Of course, one of the wonderful things that we have with the childhood cancer survivor study is we have different eras of children treated, and we can see this, we can watch this over time. That said, I will remind this audience that there is a Healthy People 2020 goal that we're supposed to improve the physical and emotional well-being of survivors, and we have no metric for that, 0. So we have our challenges laid out ahead of us. So thanks for the question. Wendy.
Wendy DeMark, Wanafried UAB, and it was a great panel, and two of the speakers brought up lifestyle issues, and I want to get clarification from Barbara Given what she means by lifestyle changes, and interested to hear about that, and then also would like to hear from Hedy Wald about how do we best provide that support if caregivers want to have lifestyle interventions.
I was talking exactly about what you were talking about. I mean, in terms of dietary changes and changes in activity level.
It was Barbara
Exactly.
Given that I was a little bit confused about.
Yes, no, that exactly the same thing.
Okay, Barbara Given.
So the studies talked about the fact that at 2 and 3 and 5 years, they were not back to running, for example. They were not eating appropriately. They had gotten used to fast food or comfort food or whatever and had not returned to running, exercise, going out, going to yoga and things like that, even though they had done that before.
Yeah, okay, well that clarifies it for me. And indeed, when we track, we haven't published our findings, but we've done some surveys in caregivers, and caregivers of children really have high needs and really do suffer from some very adverse lifestyle changes.
Just very briefly so we can get more questions in just really quick. Thank you so much for that question. I would say one of the things I was thinking about is that, for example, a list about nutrition and nutrition consults, for example, could be presented to the patient, but also presented to the caregiver, so that even if that nutrition consult couldn't be achieved there, at least the caregiver would know, your nutrition is suffering because you don't have a whole lot of time to take care of yourself, but here are some ideas for you. Here are some healthy recipes. Here are some websites. Here are some ideas. The other thing I wanted to mention, just to highlight in my talk, integrative medicine, to Dana Farber's credit, we have an institute for that, and there are some group sessions. But let's think about individualized integrative medicine interventions for caregivers, because that may help the bottom line. If their mental health is nipped in the bud early on with some minor distress, then we're not going to get into the major distress areas. Thank you.
Okay, thank you.
And I would just add to this, so from our CANCORS data that Barb Given cited a couple times. So this is a Cancer Care Outcomes Research and Surveillance Consortium, 2 large cohorts of lung and colorectal cancer survivors on which we piggyback some caregiver studies. And there we have one paper that looked at smoking concordance. And if you were a caregiver and you still smoked, you had very high distress, not surprisingly, high distress levels. So chicken egg, not sure, you may be smoking because you're so stressed, but it's not going to be good in that environment. So the idea of intervening with both parties, if they're receptive to that, but that's why it's a good question back to Hedy, when's a good time to help our caregivers who already feel, maxed out on what they can do.
Hi, my name is Eric Vinson from the Northwest Portland Area Indian Health Board. And my question kind of brings together 2 concepts that were discussed today. One sort of cultural competence understanding, and the other sort of the triage risk stratification. And how would that be implemented within a facility, given that certain cultures maybe aren't as outspoken as others? So sort of the squeaky wheel gets the grease aspect of things, I think, plays a part in like the support, the psychosocial support that certain patients get, as contrasted with other patients that may be at higher need, but they are not as communicative about their needs.
Thank you for that question. Cultural competency is difficult to implement no matter what kind of organization or institution that you're looking at. One resource that I would point people towards is in 2013, the HHS Office of Minority Health released the National Class Standards, or the National Standards in Culturally and Linguistically Appropriate Services in Health and Healthcare. And it provides 15 standards or 15 areas where organizations can work to improve cultural and linguistic competency at the governance level, at the communication pieces, whether your patient has limited English proficiency or low health literacy, as well as other considerations. But the bottom line, almost always for me at least, is the patient is the best expert on that patient. So we can talk about cultural competency up here, but there also needs to be that interaction and that cultural connection down here.
I was just going to add briefly.
Yeah.
I was just going to briefly. I think a number of us touched on this triage, screening, identification piece, and you're touching on another piece that makes it more complicated. It's a very complicated process, and it does rely on patients, providers, family members. I just think in different cultures or different groups, one has to approach it differently, involve the family, ask it in a different setting. I think if you know the particular group you're working with, you are the person who could probably guide that. But that it is more complicated than we wish it were, and it takes more time than we wish it did.
I'd just like to make a quick comment. We use a term in medical education called cultural humility, so that we're never fully culturally competent. And I think that we can use that with practitioners at a national level. I don't think it has to be complicated. I think if we can get oncology practitioners, nurses, doctors, etc., social workers, psychologists at national levels to not just have presentations with literature, literature is crucial, but also in the afternoon have a workshop. Everyone gets certified with a workshop on culturally competent care in cancer caregivership for patient and family caregivers. We can do it. I think we can. Make a module, put it into every national conference, and people have those skills and all the resources. Done deal.
Hi, Karen Basson-Anquist. I'm a behavioral scientist at MD Andersen. Thank you for a great panel, and thanks to great panels this morning as well. And I have sort of a cross-cutting question. I guess Barb Andersen might have some perspective on this, and Chris, but also maybe Paul Jacobson and others. So we've talked about screening and referral for, psychosocial issues, for symptoms, for impairments that might need rehab and things like that. And each of those have like different screening tools and kind of, as Julia pointed out, there's still not a lot of good kind of referral algorithms at this point. 4 or 5 months ago, we were in the same room talking about screening cancer patients and cancer survivors for obesity and low physical activity and poor nutrition. So I guess one thing I'm curious about, is there a way to kind of pull these different silos together and have a more comprehensive sort of screening process that's looking at all those things, even though we know the kind of referral path afterwards, the algorithm might be different? And does anybody know if people are doing that right now, or are there some good models out there for that?
Well, one model is used in cardiovascular disease in terms of screening, and that is a screening that does have obesity and other kind of disorders with it as well. That hasn't been introduced into cancer, but certainly that too is a risk factor. I mean, when I was going through the risk factors for emotional distress, I mean, that kind of paradigm can be used for health behaviors, for example, with targeted programs. I think the issue for me is just getting it on the page, getting it before them so that appropriate screening will be done, and then look at risk factors, and then try to begin to implement a triage. And it's that place that I think we're just stumbling. I don't, as Julia made reference to the distress screening, I don't think that particular vehicle has lended itself to this, as opposed to screening for specific symptoms that we know we have empirically supported treatments for.
So I think that's a great suggestion, Karen. I mean, 2 thoughts on that. One is, I can't remember exactly what's on the NCCN items as you're leaving treatment. It has some symptoms. I think it has some health behaviors. I think it does sort of global function and maybe comorbidity. That's the model. I mean, that's a nice model to think about. And you don't ask further questions if people skip out. The second, although it's being tried at the moment in clinical trial setting and for people entering trials, so Electroplascat's done something similar, where it's a global quality of life. There's some comorbid screen, there's some health behavior screening in here to monitor over time. But that same idea, you take everybody's little piece of the action and say, can we do this in some kind of a systematized way? And then you have your algorithms that go off that depending on how someone answers. I think it's a great idea. So you're in charge.
Hi, Brenda Nevajon, Oncology Nursing Society. I want to pick up on Hedy. You've mentioned more than once and given a couple of examples about education for medical schools, nursing schools. And I want to come at it from a slightly different direction because, as we know, there's education, and you can educate and see no change. So there's education, and you know this, and application in terms of behavior change. And so with the practitioner caregivers, they work in an environment that if the environment is not caring for them, then we begin to see attitude and behavior perhaps that then is not showing caring for the caregiver or attention to the caregiver. And it's fascinating to me that in the last, I would say probably 7 years or so, we've seen increasing articles, presentations, keynoters, whatever, about compassion fatigue in nursing. And now we're seeing this in medicine in terms of resilience. And that concerns me because nursing is based on the model of caregiving. The basic essentials for a baccalaureate certainly include things in terms of psychosocial care. But our members, our nurses go out in organizations that, with the pressures of everything that's happening in organizations, some of that gets lost. And I think what happens is then the family caregiver may get completely just not even seen because of what's going on with staff. So I think there's education, but I think we've got some major things to do in our care delivery models and our support of physicians, nurses, social workers, that we do keep hearing all these little things about the stress of work, the 30 patients in a time block, et cetera. And somewhere we've got to call the question, because if on the one hand, we're saying this is what we want to deliver, and people are saying this is what we want, but we've got problems in our organizations.
Thank you so much for that. There's a saying that the most resilient frog will still die in boiling water. The National Academy of Medicine just had a meeting about this. I was there last week, to their credit. Okay, we can talk about that after. I'm actually speaking nationally and internationally on this topic, and the main idea here is that it's not only about individual resilience skills training, but it's also organizational factors, and it's an integration. And we are doing more research about this and thinking about this. I actually mentioned this in my presentation. When we think about caregivers, it's also professional caregivers. The statistics on turnover rate and how much this is costing an institution and what this is doing to patient safety with medical error is astounding. So we actually have a public health crisis in terms of professional caregiver burnout and compassion fatigue. So thank you very much for mentioning that. It does trickle down and sometimes is a wave in impacting patients and family caregivers, and we must pay attention to that along with all this other work that we're doing.
Patty Gans, UCLA. I have about 5 things that I could talk about, but I'm only going to ask about 2. I'd like to bring this back to the policy issue, and I'd like us to think back to Niraj's presentation with the Shady Grove Oncology Center right across from the NCI, where all the research is being generated. Most cancer care in this country is given in community oncology practices. Those practitioners, whether they're physicians or nurses in those practices, are seeing a heterogeneous group of patients, people dying with pancreatic cancer, people newly diagnosed with leukemia or lymphoma, people diagnosed with breast cancer, and then the survivor is intermingled in that practice. And the oncologist, quite frankly, doesn't want to give up those patients because they're doing well. They look like they're doing well. They're coming back for a follow-up visit. It's surveillance. How are your kids? How are your grandchildren? Are you back at work, et cetera, et cetera? And then what do? They do a bunch of blood tests that are completely not indicated, shouldn't be paid for. They order scans, and they say, oh, we'll just make sure that everything's okay, but don't attend to all those ongoing psychosocial needs of patients. And I want to make a proposition that we need to find a way to not pay for those surveillance tests that are not indicated and shouldn't be compensated for, and we should pay for cognitive services, whether it's with a nurse specialist or a mental health provider or someone who attends to the whole person, so that practitioner can perhaps go on and see the sicker patients where the compensation and the acuity of care would be more appropriate. We need to measure this. We need to measure the value. But I put this as an extreme example of a different thing I experienced last week in clinic. I was seeing my survivor patients in clinic, and across the hall was a nurse explaining to a patient about what it was like to have an outpatient bone marrow transplant. Because at my institution and at many other institutions, people are, going to the local hotel instead of staying in the hospital, talking about what the care would be. And I'm just overhearing this conversation, and the family, I think, must live maybe 50 miles away from UCLA. But she said, well, it would be really hard to us to move to this hotel near UCLA, so I would just be close to where you are. I'd have to find someone to take care of my kids. If I could stay at home with my husband, well, I could have family and other members doing it. And I kind of said to myself, who's winning in this situation? Yes, it's better for somebody not to be in the hospital and be exposed to all of these things, but the insurance system and the hospital is saving a lot of money because they forced caregiving on the family and a major disruption that the hospital used to do. So I think we need to think about very good payment mechanisms to get the services that we need and not pay for things that are of low value. And I think that's really very important. So pay for it. If a family's going to have to stay in a hotel nearby, get some other caregivers to help them pay for it, because the insurance company's saving a lot of money. The hospital's making more money because they're getting the patient out earlier. The same needs to be done for the outpatient, where the services that patients need as survivors are not being delivered. It's a don't ask, don't tell situation. You don't ask about their mental health. You don't ask about their sexual functioning. You don't ask about their work, because they look pretty good. And compared to the rest of the patients you're seeing, they're a survivor. They're doing well.
How do we get you elected president? No, I was actually thinking about what Deb Mayer said earlier about the sort of her history, or the history in this field of taking care of the patient, because there was no one else. I think you also said there was no one else to do it, and lifespans were shorter than they are now for cancer patients and survivors. But I'm also reminded, something I had said earlier in my talk is I have to do my work differently if I want to give good care for survivors. I can't sit in my office 10 blocks away from the cancer center and have patients come in every 50 minutes and have a long chat with them and see a short number of patients every week in depth. I have to see more patients, and I have to leave the clinic. And it may be that oncologists and nurses who really like seeing their survivors and doing that, it may be, as you're suggesting, that by changing the billing and changing the reimbursement, we have to dissuade them from holding on to those patients that long. And that may be a loss for them, but it may get them to care that the patients need more acutely. But I do think it's that we have to practice differently. We can't just keep doing what we're trained to do, what we're comfortable doing, and what we're also good at doing. There is, I think, a loss for us as professionals, and I think you're pointing out the system has to nudge us to do it, because we're not going to take that loss or on our own.
Hi, this is Neeraj Arora from Picori, and thanks. This was an absolutely excellent panel. So I learned a lot from your presentations and talk, but consistent to my own advice, this panel is also making me increasingly more frustrated. And so I learned, especially Barb Andersen, from your presentation that 40 years of work, 300 papers, but the answer to Julia's question that why don't we have standard algorithms for doing this as part of clinical practice, and the answers that I hear is that this is complicated. We built it, but they've not come. So my question is, how many more years do we have to wait for this to happen? I understand the complexities, but can we really, as cancer survivors, wait for 50 years? We bemoan the 17-year statistic. Now we're talking 50 years from bench to bedside. So,
if you heard me saying it's complicated, that was a mistake on my part. I think what I do think is that a number of things have to fall into place that haven't. we probably did a few too many kind of replications of our intervention, and now we have to be pushing them out. And right now there's minimal funding to do that. The one mechanism that the one study I showed you where providers were trained, that was one grant mechanism. That mechanism worked for 5 years and now it's gone. So right now there is no mechanism, for example, at NCI for educating providers on, community providers on empirically supported psychosocial treatments. There is no mechanism. I think that needs to change. Because I think if you do build that, providers will come. They will be trained, and you will be training the providers in the country, not just providers at our NCI comprehensive cancer centers. So I think that can be done. I think that kind of the next generation of interventions, we do need to develop them in terms of going into that arena of e-health, that in terms of empirically supported interventions, going down that path, they really haven't. And that's a direction we could go, that could be providing more services to patients. But other issues like reimbursement for psychological, psychosocial services, we have now 30 years of showing that the lack of reimbursement doesn't work. So we have lots of data with the current and the history of minimal to no reimbursement, that this is what we got. This is what we got. So that's the direction of policy, and in line with the remarks that Patty was making. The system of reimbursement doesn't work. It's not there, and what is there isn't providing adequate coverage.
So Nike has a slogan, just do it. Just briefly, training, starting at med school levels, residents and fellows, there's literature out there saying they feel underprepared to work with cancer patients and their families. Make it a competency. You can do OSCE, the tests that are given before people go out in training, and you have simulation work that you do as a team-based intervention on how you're going to work with cancer patients and their caregivers. Make that mandatory in the training, make it a competency. And as far as the healthcare institution, I see a lot of healthcare institutions battling for patient satisfaction scores. Have you seen those things? You want patient satisfaction scores? Well, train, have mandatory communication skills training and assessment work in the institution about cancer patients and their caregivers, and you'll watch your scores go like this. People want those scores. It relates to reimbursements. So do it.
Here, we're actually out of time.
Okay.
It's quick.
Just a comment is, I think one of the reasons this has failed is because we haven't connected to the dots to how it matters. And so that if we address caregivers' health to patient outcomes to costs like ER visits, you would then see a loop where those kind of things would be taken care of. And I think we're sitting on a lot of data, and I think that's one of the issues with the moonshot that we talked about, is using big data to answer these kind of questions, because when care gets bundled, they're only going to care about the outcomes and what you need to do to get to them, and then that will be included because it will matter, but it doesn't in the way that we've measured it today.
Thanks, Deb. And just my comment back to Niraj, we frustrated you, but have we made you self-interested? Because that's what it's going to take. I think you're going to hear the theme here. We're here to say, what are the challenges remain? We all know that the Academies put out wonderful reports, but if we don't walk out of here tomorrow, at the end of the day, and each one of us has made some commitment, personal or on a larger scale, to move the marker, it won't move. I mean, it really does take a village. It really does take commitment, and we'll have to pick some places where we can make this happen. And I'm looking right at you, Niraj, because you put that out there, that we have to be self-interested. All of us boomers, we're up there. We're going to blow up the system. So we have to be self-interested that we get it fixed. And I want to take this opportunity to thank our outstanding panel, wonderful presentations, bringing it home and reminding us where we need to go. Thank you.